So this is the wall of a mental hospital that I worked in. I had some of my formative experiences. I trained here as a mental health nurse. And of course you don't know which side of the wall you're on when you're sitting in the audience here. And I refer back to Dr. Lucy's lecture. I would like to imagine a time where we're not prepared to put up our hand and say, yes, I have a family member who has mental health problems. Where we put up our hand and say, mental health is for me. It's something I need to take charge of, because it is, as we will see, one of the key indicators of happiness. So what I want to do in this brief overview is to look at happiness. What does it mean? If we're going to talk about happiness, what is our shared understanding of happiness? Have a look at mental illness in Ireland, the risk factors and protective factors for mental health, and then look at some of the challenges going forward to create mental health and to maybe enhance happiness. So happiness, well, what does the literature say? Most of the literature says that there's two ways of understanding happiness: as an emotion or as a sense of life satisfaction. As an emotion, were you happy yesterday? Do you feel happy now? Where in life satisfaction terms, it's, are you happy with your life? Are you happy with your position, your trajectory in life? And this raises a question: is happiness a good thing? Should it be something that we aspire to? Should it become the natural human condition? And that can be problematic. Therefore, if you are unhappy, you are some deviant who needs to be adjusted through the use of chemicals or counselling. That's quite dangerous, because unhappiness might be a completely rational position. I think it's quite ethically questionable to treat somebody for unhappiness without changing any of the circumstances creating that unhappiness. However, it would seem that happiness is in fact a very good thing to have. Most of the research, particularly, and I get on to the UN Happiness Report, which is an incredible document, people who are more emotionally happy, who have more satisfying lives, and who live in happier communities are more likely now and later to be healthy, productive, and socially connected. And moreover, these benefits in turn flow more broadly to their families, to their workplaces, and to their communities. So there's a two-way process. If you're in a happy environment, in a happy community, you can experience happiness, and therefore that community is enriched through your happiness. And in 2001, the UN General Assembly passed a resolution saying that it invited the member states to measure happiness on a national scale. And in 2012, it had its high-level meeting and produced the World Happiness Report. And it's actually quite a sophisticated document. It looks at emotional happiness and life satisfaction. And it looks at indicators, all kinds of indicators. Equality within society, access to services, so many different, it's quite a good document. So immediately when I read this, I was trying to get to the page, well, where's Ireland at? We believe that rankings don't matter, but we're kind of interested in them. And Ireland comes out quite well. You'll see we're number 18. That's of 156 countries. That's not bad. And what's interesting with this measurement is that we're only slightly lower than we were between 2005 to 2007. So in the throes of the Celtic Tiger, we weren't very much happier than we are now. So we've actually been quite resilient. Some would argue that the fall of the Celtic Tiger economy has forced people to become more socially cohesive. It's actually made communities stronger because they're being counter-aligned rather than independent. But this raised major questions for me because of my own research. There's a full chapter on mental health within this report. And it says that mental health is the single most important determinant of individual happiness in every case where it has been studied. So in any study around happiness, mental health comes up as number one. One of the key features of happiness is mental health. It's more important than physical illness, income, or unemployment. So mental illness is the single most important cause of unhappiness, but it's largely ignored by policymakers. Now, when I read this, I was quite confused, because you would have seen in the last slide that Ireland came out 18th in the rankings. However, my research would suggest that the research concerning mental illness in Ireland consistently says that we have high rates of mental illness in Ireland. So those two ideas jar with each other. If we have high rates of mental illness in Ireland, surely we must be all quite miserable. And this doesn't seem to be the case. So if we have a look at reports and the literature, and it goes right the way back. Now, I'm not an historian. I have spent a lot of time reading historical documents because I want to understand now. I want to read history so I can understand what's happening in Irish society today. And consistently we've had research saying that the Irish are mentally unwell. We're mentally unstable. If you go right back to the Select Committee to consider the state of the lunatic poor in Ireland, this was an expert group, a colonial expert group that came. And they were asked, were the Irish actually very mentally unwell? Was there a high rate of insanity in Ireland? And they said yes. I know this a fact of my own experience, and everyone acquainted with Ireland is aware of the truth. It's hereditary and therefore liable to be extended. It's connected with the habits of the lower classes people in Ireland who addict themselves to the use of spirits, and it's also connected with the use of mercury. These 4 cases are sufficient to show that it's on the increase. And this is a very important document, because this document led to the establishment of the Irish asylum system. That asylum system became the Irish mental hospital system, which is now the Irish Mental Health Service. The foundations that were laid in 1817 have a direct impact on the shape of our mental health services today, and that's problematic. If we fast forward up to 1966, there was the Commission of Inquiry into Mental Illness in Ireland. And that said, there are indications that mental illness may be more prevalent in Ireland than in any other country. And just late last year, we had a report from our friends in the College of Surgeons saying that the findings from our study suggest that Irish young people have higher rates of mental disorder than similarly aged people in other countries. So this is a little bit confusing. We seem to be doing quite well in the league table of happiness, and yet the research would suggest that we are very mentally unwell. So, of course, being a scientist, I wanted to research this area. And when I went to try and unpack mental illness in Ireland, I found the statistics very elusive. Everybody was quoting each other, saying that Ireland has a very high rate of mental illness, but nobody seemed to have done the sums. So I packed myself off to the National Library for about 5 years and did the sums. I read every report of the Inspector of Lunatic Asylums, then the Inspector for Mental Hospitals, since 1846 to date. And previous to that, I read the reports of the Inspector for Prisons. The reports for mental hospitals used to be done by the Inspector for Prisons. And I tracked the number of people in Ireland who had a diagnosis of mental illness who were admitted to an institutional setting for 200 years. And here's some of the statistics. So I get very excited about this. This took me years and years and years. These 2 squiggly lines are important to me. But what does it show? The bottom line, the red line, shows the number of people with a diagnosis of mental illness who are in psychiatric hospitals in Ireland from 1820 up until independence in 1920. And the top line is our population trend. It's our population divided by a factor of 250, and I divided it by 250 for no real academic reason other than to get to 2 lines on the same graph. I wanted to show you the trend. And what you see here is we have a rapidly growing population of, within our psychiatric hospitals, diagnosed with a mental illness. And at the same time, we've got a rapidly falling national population. And just one point, I'll come back to it in a moment, is the little bump just here. And you'll see in some of the literature that the famine is sometimes blamed on the mental state of the Irish. And I disagree. The famine is a blip on this trajectory. It didn't create a new trajectory. It's actually quite smooth before and after the famine. And what happened after independence? Well, after independence, we have sustained high rates of mental hospital use, followed by a decline from about 1956 onwards. And we have a steady population going up. If you put these two factors together, you end up with this. This is the rate of the mentally ill within residential institutions from 1850 to 2000 per 100,000 of population. How do we explain this? Well, firstly, how does it compare to other countries? So if this is what happened in Ireland, where do we rate with other countries? I was very excited about this. I wanted to press the button and see what comes out. Because I had read that Ireland had the highest rate of mental hospital usage. But nobody had done the sums. So I did. And I did an analysis of 84 different countries. I couldn't get good statistics on China. And Ireland comes out, not marginally on top, well ahead. Followed by the USSR, followed by the United States. Now, if there's any sociologists here, this is quite interesting, because sometimes sociologists try and come up with a big theory that explains psychiatric hospital utilisation. I don't think big theories are useful. I can't think of 3 locations that are more different in the mid-1950s than Ireland, the USSR and the United States. So I had to look for an explanation that was particular to Ireland. So how do you explain this? Well, one suggestion would be that we had an epidemic of insanity in Ireland that was more severe and more enduring than anywhere else in the world, followed by spontaneous recovery and up to a state of mental well-being. Well, it's funny. I agree. I think it's laughable. However, that's where most of our research funding goes to now. Understanding mental illness in this space between the 2 ears. That's where most of our services are orientated to. Understanding or delivering services in the context of what goes on in the individual mental state. So I think that's a crazy suggestion, that we had an epidemic of insanity. What are our other explanations? Well, we can go through them. Just to stress how I think this is a very important story, and I think you'll be hearing more about it in the next 2 or 3 years. These were the largest institutions of confinement in this state, full stop. They were 3 times larger than every other institution of confinement added together. In the mid-1950s, we had over 20,000 people in our psychiatric hospitals, and we had less than 400 people in prisons. I've observed a 10-fold increase in our prison population in the last 50 years and a 10-fold decrease in our psychiatric hospital population. That's interesting. The McAleese report on Magdalene laundries looked at 10,000 women within these institutions in their history. The psychiatric hospitals, on one night, we had more than 20,000. So why haven't we looked at them? I think one of the key reasons is that they were not church-run institutions. We cannot blame the church on these institutions. These were the largest institutions of confinement, and they were fully state-run. We all knew about them. We all have maybe earned money in them, or they were in our local town, played football with them, had family members go in and out of them. They predated, back to that report in 1817, the Select Committee on the Lunatic Poor in Ireland, that predated the church-state partnership that started in the 1830s in primary schooling. The church and the state did a deal in the 1830s around primary schooling, and once that deal stuck, they rolled that out to schools, industrial schools, orphanages, the Magdalene laundries and so on. The asylums predated that deal and therefore never became part of that. So if it wasn't the church and we didn't have an epidemic of insanity, it must have been the Brits. The bad Brits did this to us good Irish. And I have to say, despite our presidential visit, I would be partial to this particular explanation if it actually made sense. Our rate of institutionalisation went up, not down, post-independence. And I met with an academic, Mark Finnan, in Australia, who wrote a text on this. I've just published a book on this, Irish Insanity 1800 to 2000 is the title. But Mark gave me a good analogy. He said, if you go around Dublin, you'll see post boxes. And if you look closely at the old ones, you'll see the crown. And what we did after independence was we painted them green and we kept on going. And that's what we did with our psychiatric hospitals. We never liberated After 1922, we never went from O'Connell Street to Grange Gorman and freed the 2,000 people who were incarcerated in Grange Gorman. So it wasn't the Brits, it wasn't the land, maybe it was the land, brothers arguing about wills. There's a lot of these kind of stories. They don't fit. None of the stories really fit. There's as many reasons for admission as there was patients. And anyway, it was 50-50 men, women. So the inheritance argument doesn't really follow through. So when I was studying this, I was left short for reasons, until I started to look for reasons beyond the obvious and beyond the individual mental state. And this is a very fussy slide, but I'm going to be very brief through it. This is what drove psychiatric hospital utilisation in Ireland. Our mental health services and our expansive mental health services had very little to do with the mental state of the individuals who were admitted. Factors, for instance, the centralisation of social policy and planning for asylums. It was planned by expert groups, and you didn't have local taxation paying for local asylums. It was done centrally, decided at Westminster, administered through Dublin Castle. The Dangerous Lunatics Acts, this was dangerous legislation. The person who was admitted to a psychiatric hospital was admitted through a judicial rather than a medical process. It's interesting legislation. You could be held in a psychiatric hospital for what you might do in the future, which is interesting. A fragmentation of judicial and medical control over admission. There was a medical takeover of asylums. There was good jobs to be had, and the professions found occupational security. Mental health nurses and psychiatrists found that there was good career opportunities within these expanding institutions. There was all-encapsulating diagnostic criteria. If you have a look at 1889, the report of the Inspector for Mental Hospitals in that year would look at study and mental excitement, religious zeal, love, jealousy and seduction as diagnostic criteria. County Cork had the highest rate of love, jealousy and seduction in 1889. There was 17 female cases and 11 male cases. My wife is from County Cork, and I point this out to her frequently. So almost anything could be described as mental. We could all be admitted for some reason under these all-encapsulating diagnostic criteria. We have family participation in the asylums. It wasn't that we had bad doctors running around, hunting around Ballinasloe for patients. Families were bringing patients to the psychiatric hospitals. And we also had poverty. These provided relief for poverty. They also they were a major economic driver in the communities that they were situated in. All of these factors had nothing to do with the mental state of the individual. And the factors that interrupted this trajectory, with new legislation, new law, there was the introduction of pharmacology, ECT, and psychological interventions. Actually, psychological interventions never really took off in Ireland. Very limited. It was generally drugs and ECT was the mainstay of treatment. We have an international standardisation of diagnostic criteria. We've got belated institutional policy. Some of you will be familiar with Vision for Change, which came out in 2006. Vision for Change envisaged a time where we would close our psychiatric hospitals. Well, they were empty. That would have been visionary if it was articulated in the mid-1950s, when they were full, not when they were empty. And we have increased urbanisation and a weakening of the family power over the individual. And again, at the end of this, we've got the close of institutions, the 2001 Mental Health Act, the UN Principles for Protection of Persons with Mental Health or Mental Illness, renewed systems for inspection and legal advocacy. We have we have the emergence of mental health promotion, and we had the Celtic Tiger. It was politically possible to go to Sligo and say, I'm going to close down the large asylum in Sligo, because we weren't reliant on that asylum for jobs. That was very difficult. There was a document in 1984, Planning for the Future, which said we should close our psychiatric hospitals, and it wasn't acted on. It wasn't acted on because it was politically impossible for politicians to come back from the Dáil down to Enniscorthy or Ballinasloe or Cork and say, guess what, we're in the middle of a recession and I'm going to lead the closure of our main employer. These were like multinationals within. And you can't have a psychiatric hospital without having patients. So the key point I'm trying to make here are some key issues just on this, is that Ireland had the highest rate of mental hospital residency internationally. This was not driven by the mental state of the admitted individuals. Social forces cause mental hospital utilisation, and this is, I suppose, the key point I'm trying to make in this paper. Professional practice that developed within mental hospitals has migrated to contemporary mental health services. And that's highly problematic. And I'll tell you why I think that's highly problematic. If we have a look at, for instance, the WHO reports or the UN reports on mental health and happiness, have a look at most of the literature, you will see that there are key attributes of what protects you from mental ill health and what puts you at risk. So, for instance, risk factors: lower self-esteem, emotional immaturity, difficulties in communication, medical illness and substance abuse. The protective factors are self-esteem and confidence, ability to manage stress and adversity, communication skills, physical health and fitness. Now, I'm not part of the anti-psychiatry school of thought, and I think psychiatry has a real contribution to make to mental health and happiness. But the remnants, the professional structures and systems that were formed within mental hospitals have little control over these areas. And if you have a look at, for instance, some of the social factors: loneliness, bereavement, neglect and family conflict, exposure to violence and abuse, low income and poverty, difficulties or failure at school, work stress or employment. They're risk factors. And again, I would have to question the professional structures that carved out their traditions within mental hospitals. Are they really well placed to help us in these areas? Can they really create social support of family and friends, good parenting and family interaction, physical security and safety, economic security, achievement in education, or satisfaction at work? When I look at the environmental factors, we've got poor access to basic services, injustice and discrimination, and exposure to war or disaster. Protective factors are equality of access to basic services, social justice and tolerance and integration, physical security and safety. So I think we have a problem with regard to how we are currently delivering mental health services in this country. We had a document, Vision for Change, which is the key policy document. This was like offering the professional groups who had lost their key area of occupational security with an opportunity to write their own job descriptions. We took a different approach with the Magdalene Laundries. When we closed the Magdalene Laundries, we did not charge the religious organisations with our sexual health programmes or our crisis pregnancy agencies. When we closed, for instance, our industrial schools, we did not charge those religious orders with our child welfare programmes. And yet directly, when we have closed our psychiatric hospitals, the largest institutions of confinement in the state, the structures and systems that formed within them are still the structures and systems that we deliver our contemporary mental health services. And I think we can do better than that. I think there is a role for the professionals, but I think that is a very limited notion of mental health. I want mental health services for me and for my family. I want to be able to engage with my mental health rather than having to become a patient to access mental health services. And mental health is very, very important to your level of happiness. So my key points: the structures and systems developed in the mental hospital system continue to shape contemporary mental health service provision. I said that at the launch of my book, and I was heavily challenged by the professional groups who had turned up that night, who felt that this was a critique of their practice, and it is. My profession, I trained as a mental health nurse. I worked within institutions. I was part of what was the largest programme of confinement on this state. There's no pretty way of packaging it. The remnants of the Irish mental hospital system cannot prevent mental illness in Ireland and are poorly placed to intervene when mental illness occurs. I think there is a role. I think there's a role for pharmacy. I think there's a role for psychiatry. But if you want to, for instance, reduce suicide and improve the mental health of young men in Ireland, the GAA may be better placed to do that rather than psychiatrists or psychiatric nurses. And most of our mental health budget continues to be spent on wages, on drugs, and on buildings. That's a limited form of intervention for mental health. Mental health is the key determinant of happiness. It's very important. We need to deal with mental health. The Chancellor of this university, I saw her writing in a very personal way about her mental health, how it was challenged. That's showing real leadership of opening up that mental health is not about patients or service users or the other. Always identifying if they're mentally ill, we must be sane. We don't even need to talk about what sanity is because we're not them. I want a situation where mental health is for me, that I can address my mental health needs as I go along. So if we want a more mentally healthy and happier Ireland, I think we need a complete new deal on mental health service provision. Thank you very much.
Thank you so much, Damien. I think that was a very thought-provoking presentation.